There's a number of myths and misconceptions within our profession. I'm here with Craig Payne to attempt to demystify some of these. The first would be that pronation is pathological, or pronation increases your risk of injury.
Interesting question. If I recall correctly, I first wrote something on this 1997, so we've come a long way since then. But effectively what it is that foot pronation, and I don't want to get into an argument of what it is, I think we all know what we mean by it, is a cause of a whole lot of problems that we deal with. Plantar fasciitis, patellofemoral pain syndrome, post-tib dysfunction, the list goes on. The list has also gone on to almost the absurd level in that I've seen people try to link sweaty feet to foot pronation, in that if the foot pronates, the muscles work harder, that generates heat and the foot sweats more. So the list is getting longer and getting somewhat absurd. But if we're going to try and look at where's the actual evidence that foot pronation causes anything, and there isn't any, or if there is some, it's very, very weak. In most of the prospective studies that follow people over time and they've measured something, arch height, foot pronation, then it's not predictive of injury. So the evidence that foot pronation causes all these problems is pretty flimsy or non-existent or very weak. A couple of studies have shown a weak relationship. But at the end of the day, when we use foot orthoses to try and treat foot pronation, patients get better. And the evidence is very clear on that. Every study that's looked at foot orthoses has actually shown they work. So we've got this perhaps paradox that pronation is supposed to cause all these things. The evidence that it causes all these things is not very good. Yet when we try and use foot orthoses to treat this foot pronation, patients get better. And I see that as quite a paradox. So one way of solving that is to look at, well, what else is going on? So what a lot of my recent work and thinking's looked at is maybe it's not foot pronation, maybe it's the forces that are driving that foot pronation. And if the forces driving that pronation are great, that means the forces that need to stop it are great. And that's how we get injuries, that's how the tissues get sore. So it's not how much a foot is pronated, it's how much force was needed to stop it. And at the end of the day, that's really what it's all about. If someone has got symptoms, they've got symptoms in the foot because there was too much load in that tissue. The forces were high. The only way to treat that is to lower those forces to below a level that the tissues can tolerate. It's not about how much the foot pronates, it's not about alignment, it's not about foot posture, it's the load going through those tissues. So what an orthotic does is it changes joint moments. It doesn't have to change alignment, as long as it changes the joint moments, and joint moments are all about forces. So in amongst all this debate, how do foot orthotics work? Well, they can only work one way. They can only work by reducing load in the tissue, and they can only do that by changing joint moments.
Craig, in terms of orthotic manufacturing and modifying, what's your opinion on heat moulding?
I have a strong opinion on that. And if I could just grab this device to show here, you can't heat mould prefabricated orthotics. It is not possible to change the shape of an EVA polyurethane type orthotic by heat moulding. And what the idea allegedly is you can take a EVA or polyurethane device like this, heat it up, put it in the shoe, and have the patient stand in subtalar joint neutral or whatever position you like, and as it cools down it will hold the foot there. But the only way a device like that could do that is by changing the thickness of the material. And you can't change the thickness of polyurethane EVA by heating it unless you have a few tons of pressure, which you don't have. And if you don't believe me, what I challenge people to do is perhaps take a device like this, get some calipers, measure the thickness, heat it up following the manufacturer's instructions, put it in the shoe, have it mould to the foot, and then get the calipers out and measure the thickness again. It does not change. The only way you can change the shape of these devices is by grinding bits off or gluing bits on. You can't change the shape by heating. Except probably in one circumstance, sometimes when you heat these devices up, they might fit a bit better in the shoe initially around the heel, just to get them into the shoe. So I can accept that. But it's not possible to heat it. I certainly have people, and I know I've talked about this at conferences, and people have said things, yes, but my patients feel better when I do it that way, and my response to that is placebo.
So, Craig, you often see this 4 degrees from the subtalar joint neutral position. What's your opinion on this, and where did it originate from?
To start with, it's totally nonsensical. It does not make any sense. it's a figure that gets thrown around a lot, sometimes in jest as a solution to all foot mechanical problems. But it's not about degrees, it's about the load in the tissues. It's not about whether the foot's in subtalar joint neutral or not, it's about the load in the tissues. Someone can still be severely pronated and have no load in the tissues, or they could be severely pronated and have a high load in the tissues. You can put an orthotic with a 4-degree post on it to try and invert them 4 degrees. Some people will invert 4 degrees, some people won't. But as long as it reduces the load in the tissues, that doesn't matter. And subtalar joint neutral has also taken on a persona within the profession that is possibly not deserved anymore now. We're seeing a lot more work with things like mass theory, which is a position much more inverted than neutral, and a lot of claims being made for the success rates of that. We're certainly seeing people, maximally pronated with inverted orthotics still. There's certainly, we've got some data, others have shown data. There are some people that pronate more on an inverted device, yet their symptoms go down, and I think the evidence has quite clearly shown that. And there are people who invert a lot on an inverted device and their symptoms go down, and there are people that don't. So again, as long as the load in the tissue is reduced, that's all that matters. Doesn't matter how many degrees it is.
Craig, another opinion within the profession is that orthotics may weaken the arch muscles.
Again, another huge topic. The idea being is, are foot orthotics perhaps like a neck brace? And if you brace the neck, it's claimed that the muscles get weaker. So if you put a foot orthotic under the foot, does that weaken the arch muscles? And is that perhaps a negative thing? Well, so far 2 studies have looked at that. They've looked at muscle strength and foot orthotics. One actually showed that the calf muscles in the orthotic group got stronger than the group not wearing orthotics, so there was the opposite of that. And then there was our study, which we haven't actually got to publishing yet, in which we measured the force to plantarflex the toes when people got their orthotic at 1 month and at 3 months. Well, actually at 1 month there was a non-statistically significant increase in muscle strength, but at 3 months there was no change. So a 3-month follow-up showed they didn't weaken muscles, and another study showed that they actually strengthened the calf muscles. So to make claims that foot orthoses weaken muscles, again, the evidence is not supporting that. We certainly need more. But if you also think from a theory point of view, let's take the intrinsic muscles. When do they fire? The intrinsic muscles don't actually fire until the heel starts to come off the ground. So if someone's got a flat or pronated foot, it has nothing to do with the intrinsic muscles if the flattening happens early. And if someone's wearing a foot orthotic and the heel starts to come off the ground, the orthotic stops supporting the foot. The intrinsic muscles are still going to work just as hard. And the other thing to keep in mind is, what about neurological conditions, things like early Charcot-Marie tooth disease and things like diabetic motor neuropathy, in which we get quite a significant intrinsic muscle weakness? These people actually develop a higher arch foot. So if the intrinsic muscles were weak, the opposite happens. We don't see more pronated flat feet because of the muscle weakening. We actually see the opposite. So again, I'm unconvinced. I think people will make arguments if it suits their agenda to make that kind of argument, but the data's not looking good, the theory's not looking good for those kinds of arguments.
There's a common addition made to a lot of orthotics, a varus posting or a varus forefoot posting. Do you use this in practice?
No. Especially in people with forefoot varus. Now, forefoot varus is that problem where you supposedly hold the subtalar joint neutral and you load the lateral column, and they have a very inverted forefoot. So we have a foot that's sort of, the calcaneus is vertical and the forefoot's very inverted. So when they put the foot on the ground, they have to pronate the foot to get it flat. Now that's a true forefoot varus. It's a bony or osseous problem. There is a soft tissue contracture called forefoot supinatus that looks similar, but this true forefoot varus, it's bony, it can't be corrected by exercises or anything else. It's very inverted in the forefoot. So the theory then is you make a foot orthotic and you put a post or an elevation under the medial side of the forefoot called a forefoot varus post, so it holds the forefoot in that position and stops the rear foot pronating. The big problem I have with it is if you get it wrong. If someone doesn't have a forefoot varus and you do that, you'll interfere with the windlass mechanism, and that is the foot's main natural arch supporter. But also it does depend on what sort of orthotic you're using, and I've got here if I was going to use this softer device, semi-rigid, flexible device to treat a forefoot varus, and if I was to put a forefoot varus post, around the first met head, how's that going to stop the foot pronating? What it's going to do, it's going to have to dorsiflex the first metatarsal to end range of motion, invert the mid-foot joints to end range of motion, and then it will finally stop that rear foot pronating. Now that, to me, pushing all those joints to end range of motion to stop the rear foot pronating has got to be a bad thing. However, if I had a rigid device and I put a forefoot varus post under the medial side of the forefoot here, it's immediately going to tip and affect the rear foot through the rigid of the device. So to perhaps treat a forefoot varus with a softer device to try and affect the rear foot through a posting is potentially dangerous. It's got to jam up all those joints to end range of motion before it can affect the rear foot. Whereas a plastic device that's rigid is going to affect the rear foot immediately.